Natasha. I practice medical retina, Uvea and pediatric retina in Kochi in multiple hospitals. I was professor at Amrita Institute till 1 year back. So my topic is improving visual outcomes in pediatric uveitis, and I have divided it into 10 points, like 10 pearls that you can follow when you are dealing with pediatric uveitis. Please come, sir. So childhood uveitis, as you know, is an uncommon disease, and the incidence is only 3 in 1 lakh in the younger age group, and it slightly increases in the older age group at 10 to 14 years. But it is the most difficult to treat and can have a lot of blinding complications. The commonest types of uveitis by age up to 6 years is JIA, which presents as a chronic anterior uveitis. 7 to 12 years is idiopathic chronic anterior uveitis or intermediate. 13 to 16 intermediate uveitis and B27 associated uveitis. The classification is the same as in adults, IUSG and Sun classification. Features of anterior uveitis: the keratic precipitates, the mutton fat capes in granulomatous, festooned pupil, posterior subcapsular cataract, pigments on the anterior lens capsule, band-shaped keratopathy are all the same just like in adults, though the band-shaped keratopathy is much commoner because of the chronicity of a juvenile pediatric uveitis. The causes are JIA, juvenile spondyloarthropathies, HSV, Fuchs, sarcoid, and in no particular order. Intermediate uveitis can be idiopathic as in pars planitis or associated with sarcoid, Behçet's, Lyme disease, multiple sclerosis. Posterior uveitis, infective and non-infective entities just like in adults. Let's look at this boy. He's an 8-year-old boy with decreased vision in the right eye since 2 months. There was no any other systemic history. He presented to us with 2/60, early band-shaped keratopathy, festooned pupil with no view of the fundus because of a cataractous lens. B scan showed few coarse vitreous echoes, no RD, tumor or choroidal thickening. Referred to the immunologist and we didn't find any systemic association and everything was negative. So we gave him little bit steroid immunosuppression and did the cataract surgery. He underwent cataract surgery with IOL implantation. Post-operatively, fundus examination showed a granuloma in the periphery with some traction bands. He also had some retinal detachment later after the cataract surgery, and therefore vitrectomy was performed and a small biopsy of the granuloma was taken for tissue diagnosis and the detachment was settled. The histopathology was confirmative of toxocara. So my first pearl for you is that in a pediatric uveitis, never think that it is just an anterior uveitis. Do a dilated examination before you start the management. If you are not able to dilate and see in the OPD, see that you plan an examination under anesthesia. The second thing that we have to be aware of is the masquerade syndromes. Retinoblastoma, retinitis pigmentosa with some pigment dispersion, chronic RDs, leukemias, lymphomas, all can mimic uveitis. So this is a retinoblastoma that presented with a hypopyon-like picture. And so do not be mistaken. Again, fundus examination will tell you whether there is any tumor lurking there. If you are not able to see the fundus, at least do a B scan and rule out any tumor in the background. So have a high index of suspicion for masquerades and be sure that you are dealing with uveitis itself. Next, we will go to the most important entity in pediatric uveitis, which is JIA. It is the most common systemic association of anterior uveitis in children. These children are asymptomatic and may be picked up either on screening or when they go for some other checkup in the hospital. And sometimes uveitis can be the presenting finding in JIA. This is the usual presentation with the band-shaped keratopathy and the festooned pupil. And cataract, posterior synecdoche are common. Secondary glaucoma is very common, either a closed angle because of the pupillary block or sometimes open angle, sometimes due to the treatment also. Macular edema is the most common posterior segment complication. It does not change the classification from chronic anterior uveitis, and amblyopia and hypotony in the late stages. Points to remember in JIA uveitis is that it is a white eye with chronic course, and the systemic JIA diagnosis is criteria based. So it's very difficult for us as ophthalmologists to diagnose JIA. So when you have a child presenting with chronic uveitis, it is always better to take the help of a pediatrician or a rheumatologist, preferably a pediatric rheumatologist, to work up your patient. Methotrexate and oral corticosteroids are the first line depending on the severity. Later on we may add MMF and adalimumab in refractory cases. This was the practice so far. Western countries have now moved on to primary adalimumab because it gives very, very good results. But for us always cost is a limiting factor, so we still, and methotrexate is very effective and very low cost. So we still try methotrexate first line unless the patient can really afford and the patient comes with really severe uveitis to start with. Topical medications have only an adjunctive role, and you should not be using more than 3 drops for more than 3 months. So if you are having to use that, you must step up your systemic immunosuppression. There is no question of treating these children with topicals alone. They should be on systemic immunosuppression from the beginning. Slow tapering of the topical steroids with constant monitoring of the activity and IOP is required. Risk factors for ocular involvement in JIA are female sex, oligoarticular, which means number of joints involved are less. The earlier the onset, the more the risk factor. ANA positivity, RF negativity, and the screening frequency in high risk JIA, when they have these features, there is a lot of different like ways in which you can screen, but the easy one to remember is that you screen 3 to 4 monthly in high risk JIA and you screen 6 monthly in low risk JIA, and low risk, high risk you classify depending on the presence of these features. So my pearl number 3 is that topicals are not the mainstay of treatment in JIA uveitis, and you should not be starting topicals alone in these children. And also you have to do a screening for all JIA children, and if you have a rheumatologist or a pediatrician in your hospital, they will be referring to you, and you have to do it with a slit lamp examination. Just seeing the patient in a torchlight or just seeing vision and sending the child is not enough. You have to do a slit lamp examination in all these children with JIA. Juvenile spondyloarthropathies make up 15% of the pediatric uveitis, and they include juvenile AS, juvenile Reiter's, juvenile psoriatic arthritis, ulcerative colitis, and Crohn's disease. Unlike the JIA uveitis, these children are usually presenting with an acute symptomatic anterior uveitis, sometimes with hypopion. Points to remember: mostly boys, mostly older age group, acute symptomatic recurrent uveitis. Many are HLA-B27 positive, and they have a very fibrinous hypopion uveitis. Inflammatory bowel disease, Crohn's and ulcerative colitis, they present with a mild arthritis in childhood. They present with episcleritis or acute anterior uveitis. Here the important thing is to sensitize the parent, because it's a symptomatic uveitis. They will usually have redness, pain, photophobia, but the problem is that the parents don't know about this entity, so they think it is conjunctivitis or they think it is some other redness, allergy, and they don't take for treatment. So until it becomes really severe. So you have to sensitize parents with IBD and Crohn's disease that when there is a redness, they need to show the eye specialist as early as possible. So not all pediatric uveitis are asymptomatic, and when it is symptomatic, it is not usually JIA. This child, 10-month-old female baby with abdominal distension, recurrent loose stools, and progressive skin lesions, failure to gain weight. These were all the features. There was pallor, edema over the hands and feet, depigmented hair, hypopigmented scaly lesions. Ophthalmic examination showed bilateral anterior uveitis with festooned pupil in both eyes. There was anemia, skin biopsy showed granulomas, liver biopsy showed granulomas, stool was positive for occult blood, endoscopy showed granulomatous duodenitis and granulomatous colitis. The NOD2 gene mutation that is done for a condition called Blau syndrome was negative, so the diagnosis is an infantile sarcoidosis. This child had a long and stormy course, improved well with systemic immunosuppression, initially with methotrexate and MMF, later shifted to adalimumab, underwent cataract surgery in both eyes. She is now around 12 years old, going to school and doing very well. So infantile sarcoid, early onset childhood sarcoid, is a rare disease, and it appears to be different from sarcoid in older children. It occurs in half the cases there is liver involvement, so liver biopsy is an important diagnostic tool. Patients with early onset sarcoid present in the first year of life with rash, uveitis and arthritis in a child younger than 4 years. The differential diagnosis is a familial condition called Blau syndrome, which is autosomal dominant and has the similar, very, very similar presentation. Only thing is that the mutation will be positive. So very severe uveitis that presents very early, you have to keep these two conditions in mind, Blau and infantile sarcoidosis. Behçet's uveitis, pediatric Behçet's is onset of uveitis at 16 years of age or younger. The mean age is a late childhood, it's a male preponderance, sometimes has a family history. Bilateral involvement is common, presence with a recurrent panuveitis with retinal vasculitis, and these are HLA-B51 positive. And Behçet's is more common in our population than we think, and it's a clinical diagnosis. The HLA-B51 has only a supporting role. Next we go to management of pediatric non-infectious uveitis. All pediatric uveitis have to be investigated. Rule out masquerade before you investigate. Assess activity and sequelae to decide the management plan, and you need cooperation from a pediatrician and a rheumatologist. Topical corticosteroids are initially used for treatment of anterior segment inflammation, and it is the same dictum as in adults: hit hard, hit early. So don't start in inadequate doses 2 times, 3 times. When you are starting your topical steroid, you start 6 times, 3 hourly, and if it's a hypopion uveitis, you start hourly or 2 hourly for the first few days. Then you can make it 3 hourly, and then you start the taper depending on, do not give an automatic taper. You say you give the patient 6 times for 1 week, 5 times for 1 week, 4 times for 1 week without seeing the patient. Don't do that. So you start 6 times, call the patient back, see how it has responded to your topicals, and then you taper according to that. Children have a very high incidence of IOP rise, so you have to keep monitoring the IOP at every visit and try to taper and stop your topicals as early as possible. The next important part of our treatment is treatment of the sequelae. The BSK needs to be treated, the cataract needs to be treated. So cataract surgery with posterior chamber intraocular lens implantation is possible in these children. They do not have to be left aphakic like we were doing before, but you have to ensure an activity-free period of at least 6 months before cataract surgery, steady systemic immunosuppression, and give systemic steroid cover 2 weeks prior and continue for a month after. Then you slowly taper the systemic and topicals. Remember that you cannot taper the topicals like you do adult cataract surgery. You have to taper it really, really slowly, sometimes over 6 months. Hypotony to begin with is catastrophic, so do not operate a child who has hypotony less than 10 IOP. You must step up the IOP with your steroids and then only take up for cataract surgery, or you will end up in phthisis. If there is severe vitritis, retinal involvement, uncontrolled inflammation, it is better to leave it aphakic. Never operate a pediatric uveitic cataract without adequate immunosuppression. Band-shaped keratopathy, you can do EDTA chelation or phototherapeutic keratectomy. Again, if your inflammation is not controlled, it will keep coming back. Cystoid macular edema, you can treat with posterior subtenon or dexamethasone, but you have to give a short GA in these children before you give, and keep a high lookout for raised intraocular pressure. Secondary glaucomas, depending upon whether it is open angle or closed angle, first line management is always topicals. Carbonic anhydrase inhibitors work well, beta blockers work well, ripasudil and PG analogs as last resort because they will increase the inflammation. And finally, if it is not getting controlled with AGM, or if you are having a severe angle closure, synechial angle closure, you have to go in for surgery. Valve surgery is preferred to trabeculectomy. Fine. And if you have very poor prognostic eye, you can also consider diode CPC. This is my last case, 12-year-old girl, bilateral panuveitis with vitreous haze, complicated cataract, BSK. She presented to us with irregular treatment in various places, with hand movements in one eye and 6/60 in the other eye, and hypotony. So in this case, there is really nothing you can do to give her ambulant vision except go all in and do surgery. So under immunosuppression, we took her up for cataract surgery, vitrectomy with oil. Under oil, she is maintaining 6/12, but we are not able to remove the oil because She has severe hypotony even now. So sometimes you need vitrectomy, sometimes for diagnosis, mostly therapeutic when you have vitritis, and severe vitritis that is not going away with your steroids. And because of the small gauge, now there is less morbidity, so you can still consider it even in children. So in conclusion, pediatric uveitis is like an obstacle course. It has a lot of twists and turns in the journey, but it's a very rewarding specialty because you're saving the eyes of these children. I have a small charity that I do for pediatric uveitis. It is called Childhood Uveitis Blindness Support, and it was inaugurated last year. And if anybody has any child who would like support from the thing, that also you can approach. If you want to contribute monetarily, that also I'll be happy to accept. So with that, I will end my talk. I'm glad at least I had a small audience today morning. Any doubts from the audience? Dr. Trisha Shrestha, is this session? 10:15 session. All right. Anybody, any doubts? Yeah, infections are the most commonly toxoplasmosis is the most common infection that we see, but it's a very classical clinical picture. So we go by the clinical picture, but TB has to be ruled out in all the children before we start systemic immunosuppression, definitely. So toxo only if the clinical picture suggests it. You have to plan? EUA, yes, yes. Many times you will need a EUA for the full examination. But generally they are very, most of them once they keep coming to you, then they become cooperative. First examination sometimes you require. Onset before the age of 4 or 5 years is not very common. When it comes before 4 years, then you have to keep a high index of suspicion for sarcoid. Yeah. JIA uveitis usually presents a little later, like 4 to 6 years kind, but 0 to 4 years it's not that common. But sometimes the thing is that if the patient has arthritis, then when they send you for screening, that time you can pick it up. So what I usually look for is you can't do EUA in all these children, no? When they're coming for screening, if you pick up an abnormality, then you can plan, but screening, then EUA is difficult. So I can either sedate, pedichloral sedation, and then examine with a handheld slit lamp, or if you don't have a handheld slit lamp, use the magnification of your indirect to look for synechia, any visible KPs, any BSK at the sides. These things you can pick up very easily in the OPD itself. TB, I didn't mention it specifically, but before systemic immunosuppression, even before systemic steroid, a quantiferon has to be sent. Yes, yeah. But generally the viral retinitis kind of pictures, most of the infections that we see in adults are not very common in children. So you don't have to worry too much about that. Okay, with that we'll wind up this session. Thank you very much.